mainly the arcuate fibers are more affected in glaucoma, and this is the area which we assess while doing the visual fields in the patients. And irreversible visual field loss occurs in glaucoma due to loss of the retinal ganglion cell, as can be seen here. And the aim, and we get these dense defects like this. But the aim of the glaucoma management is to avoid such severe loss of RGCs. So light, what happens? Light is detected by almost all the RGCs. But specific features like contrast sensitivity, color vision, movement perception are perceived by specific types of RGCs. So only some RGCs detect these things. So if one subset of cells is tested, a defect may be detected even if a small proportion of these retinal ganglion cells are affected. So this is the principle of all these newer, most of these newer perimetry techniques. So the RGCs are of different types. About 80% of the cells are the parvocellular P cell types, which are sensitive to both color and contrast. About 5% are the coinocellular K cells, which are responsive to the blue-yellow colors. And about 15% are the magnocellular MY cells that react to the temporally modulated stimuli. So as we all know, standard automated perimetry, the white on white, detects a visual field loss when about 40% of the RGCs are lost. Why is that? Because we have a lot of redundancy or a lot of reserve is there in the body. And unless a large number of cells are lost in the white on white perimetry, a field defect is not seen. So, but the frequency doubling technology and the shortwave automated perimetry swab may help us to detect early damage. So what is this frequency doubling technology? This is basically based on a flicker illusion. So there is a counterphase flickering of these low spatial frequency grating. This grating here is white and this side is black. So they flicker, the black becomes white and the white becomes black. That is what the flickering. And this flickering occurs at a high temporal frequency, about 15 hertz or so. And because of this flickering, one sees a phenomenon in which the number of gratings appears to be double than the actual number. So this is what is the frequency doubling technology which is used. This is the frequency doubling stimulus. So how does this frequency doubling technology perimetry work? As we had discussed, early glaucomatous nerve damage is thought to be due to the loss of the large diameter RGCs, the MY cells in the magnocellular layer. And as we have seen, they are only a small proportion, about 10 to 15%. So this may be good for detecting early damage as there is less of functional redundancy. So as fewer cells are only lost, we might be able to detect a defect. So this is an image of the Humphrey FDT perimeter. And this is how the stimulus looks for the patient. So the testing is, what are the advantages? Testing is done under normal illumination, no patching is required, no pupillary dilatation is required, and there is no need for giving any correction if the refractive error is within plus minus 6 diopters. So this is how the printouts look. So there are both screening and threshold programs. So the screening can be done with a C20 and an N30 test. So what is the C20? Basically, it measures the central 20 degrees of the visual field. And in the N30, there are 2 additional points in the nasal side to look at for any early nasal step. So what basically the image does, we have a fairly large size target, 10 degrees target, and 4 areas are tested in each quadrant, and 1 central quadrant, which is at 5 degrees. So total 17 points are tested in the C20 program, and here 19 points are tested. And also fixation errors, false positives, false negatives are checked. And if a defect is detected, it gives the probability symbols depending on the shading of the probability symbols. And so now, when we come to the threshold program, in the threshold program, what happens? Each point is tested at various contrast levels, and the minimum contrast noted at each level is given as a threshold, which is given in a decibel, similar to a standard automated perimetry. And to get this thresholding, they do the reverse staircase threshold. Like if a person is able to see one point, then the thresholding is reduced till the person is not able to see, then again increased, and then again decreased. 4-time reversals are done. And this is known as a modified binary search algorithm. And once the threshold is given, again the deviation map is made. Here, this is a normal test, so there is no deviation noted. This is the blind spot. And then global indices also come, like the mean deviation and the pattern standard deviation, and the fixation errors are also noted here. So this is how the full threshold program is done. Now the issues with this normal FDT is that the target size is quite large, 10 degrees. So in such a situation, small defects might not be picked up. And to rectify this sort of errors, a newer machine was made, and this is the Humphrey Matrix 800. This is the newer version. And in this, basically, this is how the stimulus is seen by the patient. They fixate at the central point, and these contrast gratings are seen at different points. And when they see a stimulus, they have to press the buzzer. So this is how the machine works. One more advantage which this new machine did, they made a chin rest also, which makes it very comfortable to the patient, because the earlier machine did not have a chin rest. So this is how the reports will appear. So what are the differences? The smaller targets are presented in this machine. And it has all the programs like a 24-2, 30-2, 10-2 and a macular threshold program. And the 24-2 and 30, while the 10-2 and a macular test use 2-degree targets. So basically, the targets are, each threshold is measured at all these points, similar to a Humphrey standard white-on-white perimetry. And there are both screening programs and threshold programs. In threshold programs, they use the 2-step reversal instead of the 4-step reversal, which reduces the time used. The other thing what is there, one more program is there, which is similar to CETA, where there is no reversal done. This is known as the ZEST program, the Bayesian Threshold Estimation Strategy, similar to the CETA, which is present in white-on-white perimetry. So once the test is done, we get a report similar to a standard perimetry. The reliability indices, the test time is given here. The type of test being done is noted here. And then the raw data or the threshold levels of each point is given here. And then we get a grayscale here. Then the total deviation plot and the pattern deviation plot is given here with the, and there is a glaucoma hemifield test also, and also the mean deviation and the pattern standard deviation, the global indices are given. So this is how the Humphrey Matrix FDT gives us a good result, and many studies are saying that it may be as good as standard automated perimetry as far as looking for glaucoma progression. Now coming on to shortwave wave automated perimetry or SWAP. This basically helps by tries to detect loss of the K cells, which again are a very small percentage, about 5 to 10%. So basically what happens, there is a yellow background, and this yellow, intense yellow light will bleach the red-green cones, and only the blue cones are isolated. And these are more susceptible to glaucoma damage. So here we have the lighting is of 100 candela per meter square, and the stimulus used is a large Goldman size 5. So the standard Goldman perimeter uses size 3, but here the large size 5 is used. And prior to testing, the person has to be exposed to the yellow light for about 5 minutes or so that the red-green cones are bleached. But the issues with SWAP are basically there is a high inter-individual variability and longer learning curve has been noted. And if there is any nuclear sclerosis cataract, that may influence the results and may show false negatives. And patient fatigue and long adaptation time are some of the problems which have been noted with SWAP. So here we see a SWAP printout. So it is similar to a standard white-on-white perimeter. Main thing is Here we have our reliability indices, and here we can see the strategy used is full threshold, color of the background is yellow, stimulus is blue, and the other parameters. Now you can see this takes a long time. This is a 26-year-old person, and the time taken is almost 20 minutes. So that is why there is a lot of tiredness, and the other readings are similar. We have the raw data, the grayscale, the total deviation numbers and the pattern plot, and the total deviation and the pattern deviation, and the glaucoma hemifield test. And here, as it is a full threshold, you get the four global indices: the mean deviation, the pattern standard deviation, short-term fluctuation, and the corrected pattern standard deviation. But now newer machines have swap with CETA strategy also, which has reduced the testing time, and that is what is mostly used. Now let us look at some of the newer other things which are developing. This is fundus perimetry or microperimetry. Basically in this, there is a constant imaging of the retinal points with a confocal scanning laser ophthalmoscopy, and the threshold of each point is measured. So if there is any fixation loss also, that can be corrected well with this machine. So in this printout, this is the compass perimeter. One gets the optic disc photograph, and this is the imaging each point where the threshold is measured, and the total deviation map and the pattern deviation map is given along with a grayscale. And also the glaucoma staging system 2 of the Brucini's glaucoma staging system 2 is there, and one printout, one assessment is given. So this is also, these are not really used in clinical use much, but mostly used for experimental use at this current point of time. Now another thing when we look at perimetry is that many times it is difficult to do perimetry for a person who is in bed, who is tired. So this is an iPad based perimetry, basically like a tangent perimetry fields. And in this, the stimulus is shown on the iPad. This is the red fixation mark where the patient should keep looking, and this keeps moving. So as the fixation marks keeps moving, the patient should keep fixating at that point, and different stimuli are shown at different points to map the visual field. This has been found to be fairly effective. Various studies have shown good correlation with standard white-on-white perimetry. And so here, this is a study case report of this perimetry. A patient with pituitary tumor, a bedside field was there done, and the bitemporal hemianopia is being noted by this machine. So this is another interesting machine which is recently started becoming available in India. Then another major problem for us is we have a large rural population who is not able to come to our hospitals to get checked up. So this virtual reality instrument using peripheral vision testing is very promising in this situation. This is being developed by the Arvind Eye Hospitals and a commercial company. And this is a C3 field analyzer. Basically, the stimulus is shown in this virtual reality monitor, and the patient has to press the buzzer. And the reports can be seen in any instrument like this. It can be wirelessly transmitted. As of now, they have validated a screening protocol. Threshold protocols have not yet been done. So this is something interesting which might help us in the future. Another very interesting technology being developed in Shankar Netralaya and a European group. This is the eye movement perimetry. So normal perimetry when we do, we have to do something which is not physiological. We have to keep looking at a straight point where when a stimulus is shown. But what is the normal human reflex? If you see a light or a blinking thing, we tend to move our eyes towards the thing. So now this technology basically shows images, shows the target in different points of the screen, and the person does not have to do anything, blink, press a button or anything. They just need to follow the target. And there is a gaze tracker which monitors the patient's eye movements. So once, as the patient moves, they do a saccadic movement, and this machine will test the speed of the saccadic eye movement. The saccadic reaction time is taken to measure the visual field. And they have found that it gives a very good correlation as of now. This is the standard white on white perimetry of the patient, and this is the eye movement perimetry results. So this is something very interesting, and in future it may give us a lot of help to the patients, because as we see, many patients do not want to really do a perimetry because they find it very difficult to do. So this is under development. So these are some of the newer things which I thought I would share with you. In a short note, they might be helpful. Thank you.
Thank you, sir. I think it was a very useful presentation. I remember talking to a few PGs and they wanted to know about new perimeters. So a lot of new stuff you shared, especially eye movement perimetry and virtual reality and even iPad. I think something like iPad, even now we also can try, because currently we are trying more of e-consultation. So I think.
No, this iPad perimetry has been recently, it has been developed in Australia, but recently they got permission in India also. It's being marketed recently, the Melbourne Rapid Field.
May not necessarily be for treating, but at least you can get do a good screening and.
Yeah, you could do good screening, or when the patient cannot do a formal fields if they are not well or something. So those are things.
So congratulations, Aditya. That was very well covered.
Thank you, sir.
I think we have one or two questions, like what is sharpened edge in a optic disc, sir? Right? You like to, personally I must say I've never heard this question, but in case you want to.
So I'll explain that. So you have what is called as a sharp upper border. So when the cup rim junction is such that sometimes the upper or the lower border of this junction is very well demarcated, we use the word sharp demarcation, sharp edge. So the problem here is, Maneesh, that the description will not have standardization. So everybody is going to use terminology based on where they have been trained. So it's quite possible this person was exposed to or saw case notes of somebody who's using this term.
Yeah,
and therefore they are using this.
Some of the terms may not be in textbooks. It's more like a term used in a particular clinic for a particular.
Yeah.
I think, sir, we have covered most of the questions in our presentation. So if we don't, I think we just have one more question.
So before you come to that, can I come back, because we are dealing with postgraduates. So one of your questions here is, if you have a patient with glaucoma, which fields will you do? Some of the newer things that were being mentioned, or would you do white on white perimetry? So remember, the gold standard is white on white perimetry, not even a blue on yellow. So do not accept a blue on yellow, an FDP, or any of these newer printouts to say that you will make a diagnosis on the basis of these tests. You can rely on these tests, but the diagnosis has to, the fields have to be repeated with a white on white perimetry to make the diagnosis. Just remember this.
Yes, yes. So,
there is a question on what is meant by the raw data. Basically, that raw data is the number of, that is the threshold for each point when the test is done, what each patient has done. And then the machine uses this raw data and correlates it with the age match normal. And that is how the machine is able to tell whether that particular point is affected or not affected, or if it is affected to what extent. So that is what the basic thing is meant by raw data.
So one question I have for Dr. Aditya Neog, sir, in your practice, what are the cases you consider doing a swap test? Because I remember when long back it was used more commonly. Over time the use has gone down a bit. Any particular case you think swap can be useful?
Swap test is not being done much now, because newer studies seem to show that it may not really give an added advantage, while FDT might give. But that is not, as far as exams are considered, we will not discuss that point. Maybe a very young patient who has family history, white on white is normal, everything is normal, little high pressures, patient is anxious, maybe CETA swap might be what we would consider.
CETA swap, I think, is important because
yes,
it saves a lot of time. A normal swap is really quite...
Yeah, very tiring for the patient and difficult to do.
So the question, I think, which sir was also mentioning, whether there's a question whether we should do 30-2 or 24-2 for glaucoma.
Yeah, I prefer to do a 24-2 for glaucoma because, like we have seen, we are basically, if we feel it's glaucoma, we are going to look at the superior and inferior arcuate fibers. And that is what is covered by the 24-2 because we get the nasal area also. So I would prefer to do a 24-2 in most patients when I look for glaucoma.
Dr. Sood sir, one question I wanted to ask you, because a lot of time we get these myopic patients. I think you did also touched about it in your presentation. And sometimes even with a very experienced ophthalmologist also finds it really difficult to understand where there is thinning because these discs are very difficult to evaluate. So in these patients, when the pressures are high, you can treat on the pressure, but when the pressures are also normal and the disc is difficult to evaluate, what practical tips you can share, like how to deal with cases like these, or just keep them of the observation?
So Maneesh, that's a very good question actually. And what I would like to emphasize is clinical examination becomes important. Visual fields become important because in a myopic disc, the tilt, the large size will anyway make disc morphometry with the HRT or the OCT redundant because they'll produce red disease. So fields will become your key, and even then you can miss out things actually. So the dictum actually is when in doubt, treat, and then come back and revise your treatment over a period of time.
Thank you, sir. I think it was a pleasure to have both of you, sir, Dr. Sood sir and Dr. Aditya Neog, and had a great fortune to work with Dr. Aditya Neog sir during my fellowship at Shankar Netralaya. So for me, it was a very good learning session. I learned a lot of things. I'm sure for PGs, it will be great listening to so many important points for disc evaluation and also the neuroperimeter, which they often get questions as a short note and even as a viva question. So I'll hand over the session to Dr. Satyajit.
Yes, you rightly said, Maneesh. I think we are ourselves becoming wiser each day. This new thing I learned from Dr. Sood's presentation about the fish oil, that aspirin is high in that.
Exactly, yeah.
Yes, that's a new thing.
Such a new thing for me.
I learned it the hard way.
So I'm really very grateful to Dr. Devendra Sood and Dr. Aditya Neog for their time and valuable presentation which they have made. We have not recorded Dr. Devendra Sood's presentation, so the postgraduates will not have a chance for that. Sir is presenting in a lot of prestigious meetings. You can listen to him over there. We have recorded Dr. Aditya Neog meeting, which will be shared to the postgraduates. Starting Monday, again, we will be going back to retina like we were in the last week. And then after that, we will have one more week of glaucoma and then cornea, cataract and all those things. But next week, we will be starting with retina, and Dr. Saurabh Sinha from BBI Foundation will be moderating the session. So I want to thank all the postgraduates once again who were there with us for being with us. And if you have taken any pictures from even any of the presentations, please delete them, because if you don't have the author's consent, all the postgraduates, and thank you, sir, and thank you, Dr. Aditya Neog. Thank you so much.
Thank you so much. It was a pleasure.
Aditya and Maneesh, it was a real pleasure being there.
Thank you, sir.
Thank you for asking me questions for which I knew the answer.
You know all the answers, sir.
Hi, Aditya.
Bye, sir. Thank you, Maneesh. Thank you, Dr. Sinha. Bye, sir.
Thank you, Aditya.